Now let's turn our discussion to fall risk and how that's treated, how it's taken care of, the precautions one should take. And with us today is an expert in that. His name is Dr. Jonathan Moore, who is a podiatrist and, as I said, specializes in fall prevention. Welcome to the show, Dr. Moore.
Thank you very much, Ed. It's a pleasure to be with you.
Now, tell us a little bit about yourself, your qualifications. I know you're a podiatrist, but what from your past, your childhood, and everything like that led you to podiatry? Number one, and number two, what led you to specialize in fall prevention?
Well, listen. First of all, I'm from Texas. I grew up in Tomball, Texas, north of Houston. So
then you've got to be a good guy.
It's an honor to be talking to some Texas folks, and of course, it's really an honor to be speaking with you. So I grew up in the Houston area in Tomball, and went to college at Texas State in San Marcos, and then went to medical school in San Francisco, California, at UC.
Poor guy.
And for those that don't know, podiatrists go to medical school 4 years, just like any other physician, and then do a residency like other physicians. So I did my residency at the University of Texas in San Antonio, and specialized in diabetes and limb preservation and those types of things. But I married a girl from Kentucky, and that's how I ended up in Kentucky. And my wife is an occupational therapist who has a great interest and specialty in balance and fall prevention and vestibular problems that can cause falls. So my interest came from her as she was treating patients and was working at our physical therapy center. I became interested in the lower extremity aspects of falls. And Ed, you'd be amazed at when you look at the causes of falls, how many of them relate directly to the feet and ankles.
Well, that was going to be.
And so that's kind of what led down the path of me exploring, researching, and I'm fortunate enough to be in a clinic, and we actually have a physical therapy department in our clinic. We started implementing some physical therapy treatments for those that were seniors at risk for falling, and then I developed a product that is an aid, a mobility enhancement device that helps reduce falls, and that's ultimately kind of what led me to become someone that spoke a lot about this to other physicians, and I think we've made some huge impacts on people's lives in helping to reduce falls.
Well, let's back up a little tiny bit, and let's review the types of conditions that you deal with that could put somebody at risk for a fall.
Yeah, that's so. When you look at the medical literature, the number one cause of falling is muscle weakness, and so when you look at risk factors for falling, muscle weakness. So when you think about it, of course, as we get older, several things happen that are unfortunate. Number one, our lower extremities and our upper body extremities become weaker, and ultimately we also begin to lose a little bit of the neurological sensation in our extremities, which reduces, of course, our ability to feel or what we call proprioceptive sense. That also leads to falling, but certainly anything that can alter gait can produce a fall. Like, for instance, osteoarthritis in the ankles or feet or back that alters the way the patients stand. You've seen the pictures of course, seen patients yourself, Ed, where patients were humped over a walker, and so mechanically they're just significantly altered. So there are musculoskeletal causes that include arthritis, but the number one cause is muscle weakness, and then you have also neurological causes. Patients clearly, as we get older, they lose proprioceptive sense, so you have that, and then you also have assistive devices which oftentimes can cause falls as well. So, but another common cause, Ed, that is vestibular causes, and for those of you that may not know what the vestibular sense is, that's an inner ear problem that can occur as we get older, and it can be altered such that there's dizziness, maybe the feeling of vertigo and those types of things, which can alter balance as well. So the key thing is that there's lots of causes, and there's not just one treatment. Because this is a multifactorial problem, you can't attack it just with one thing. You've got to approach falls from a multifaceted standpoint.
Okay, well then, what type of things do you do to evaluate a patient and assess that patient to be at fall risk?
Yeah, so that's a great question, and you know what, one of the most accurate and yet simple questions to screen patients to determine risk is asking if they have fallen before. Believe it or not, studies have shown that if a patient has a history of a fall, a single event, their likelihood of falling is precipitously higher, falling again. And so the most simple screening tool is simply asking the patients if they've fallen. So the history of falling is a vital importance. And so you also, of course, and this is unfortunately where there's a huge gap in recognition of how to do it and then actually performing these types of assessments. But you have to watch the patient walk. And unfortunately, family doctors and many internal medicine doctors who see these patients just simply don't do this. But if you watch the patients walk and look at their gait, look at specifically how balanced they are when they when they walk through a doorway. Are they holding onto the wall? Are they using a cane? Are they dragging their feet? So doing a gait assessment, it can be very valuable. Well, but in addition to that, there are objective fall risk assessment tools, and there are several of them that are out there. We use one that specifically looks at lower extremity risk factors, but just even asking simple screening questions can be very valuable.
Well, what about the, because we all know, especially with men, we don't always report well.
Yeah, that's great. Yeah, that's a great point. So what studies have shown, Ed, is that patients that go to their family doctors oftentimes don't report falls or don't admit to falls. And I think one of the worst, sometimes the worst question to ask a patient is if you've fallen. Because patients oftentimes get defensive and they oftentimes will deny falling. What I do in my clinic is I ask the patient, instead of directly looking at them and saying, have you fallen, I will ask the patient, how steady are you on your feet? And what that typically leads to is them admitting to falls, because seniors, and maybe it's men more than women, I don't know, but seniors as a whole are afraid of admitting to falls because of fear of loss of independence. They're fearful of what may happen. They're fearful of losing their privileges to drive or whatever the case may be. So unfortunately, it's the case that we oftentimes have to kind of ascertain their history of falling through more subtle questions up front. And that's one of the things that I've written about and talk about to other doctors as far as asking the right questions in that way.
But this doesn't just happen, when I say just happen, geriatrics is not the only group that would be at risk for falls. Am I correct?
No, it's not. It's by far the majority. However, another category of patients that is at really high risk of falling are diabetic patients because of the nerve damage in their extremities.
Neuropathy.
There's a large number of patients that are out there that aren't necessarily, I would say that maybe are in their 50s or 60s, that wouldn't necessarily be on a cane or walker, but would have a tremendous problem with balance because they just simply have neuropathy, which is a neurological deficit that's common in diabetic patients. But you also, of course, have patients that have Parkinson's, which are typically older patients.
Right.
They're at significantly high risk of falling. And then, of course, you have patients with MS and other conditions that are neuromuscular disorders. But you're right. Seniors by far fit into that, and they're by far the majority of people who are falling. And of course, they constitute the most expensive aspects of falling because of their likelihood of breaking a hip and needing more care in the hospital.
Now, are there any kind of mechanical devices that you might use in assessing that patient as well?
Well, so when you look at some of the fall risk assessment tools that are out there, there are a number of them. I would say that there are probably 30-plus different fall risk assessment tools. Mm-hmm. And when I say tools, I'm talking about assessments.
Right.
Now, most of them do not require any instrumentation at all. Most of them require a combination of looking at their medications, because we haven't discussed this, but medications are a large cause a lot of falls. Patients that are on a number of different medications. So the most common and the most effective fall risk assessment tools are a combination of asking the patients, and looking at what medications they're on, looking at their medical conditions, in combination with a mechanical bioevaluation. That means walking, assessment of joint mobility, and then, of course, doing testing to evaluate proprioception. And so those are the most effective tools. But there are fall risk assessments that are literally, 5-minute assessments, where you ask the patient how many times they've fallen. You assess a few other very simple things, and that's done. So you can find them really all over the map as far as sophistication. But it doesn't really require any specific equipment.
But in the patient that doesn't have neuropathy, is the typical type of fall risk, isn't it important to establish what's causing the patient to be at risk?
I think it's critical, and I think that in some cases, well, I would say in most cases, Ed, it's not just one thing. There's probably 5 things, and that's what makes this such a complex thing to treat. Mm-hmm. When the patients come into you in many conditions, we're looking for just kind of one smoking gun, but in the senior patients, it's probably 5.
Yeah.
And so, if a lot of the time, I feel like that if I can identify 3 out of the 5, I'm going to significantly reduce their chances of falling. If I identify the main cause of their imbalance, I feel like I'm doing the patient a great benefit, if that makes any sense.
Sure, it makes a lot of sense. One of the reasons I was asking about these types of tools is that I recently saw a balance testing machine, which was more than just standing on a pressure plate device. A force plate, that also did various kinds of grouping tests and things like that to be able to identify where in the brain is this happening that's causing the fall. So it was made in Australia. I don't know if you've heard about it.
Well, yeah, we actually have that machine.
Oh,
we have it in our physical therapy department.
Oh.
And now, those devices I don't think are, although they can, I think, in some cases be helpful if you're looking at much more specific, like for instance, those pressure plate devices are really measure both proprioception and postural stability. Mm-hmm. And we use them in our physical therapy area to gauge where they're at, so we can focus on postural stability with strengthening and those types of things. So those can be good tools. That none of those types of devices are typically listed among the screening tools because they're very costly. You'll find more of those instruments in physical therapy centers or balance centers, where they're used to do an assessment and then of course to focus on the areas that are weak. And then when you're talking about the brain, there's certainly dementia and other common types of dementia can certainly cause imbalance and increase the risk of falling. But probably one of the more recognized is vestibular. And our physical therapy center here in Kentucky, we sent our physical therapists to become certified in vestibular testing. So there are specific tests that can be done for vestibular etiologies as well.
Fantastic. What is... we know that there are costs involved. What is the overall cost? And maybe I'm asking a question that, I should be looking up.
No, well, it's a great question because I was actually prepared to answer that question because it's a staggering number. So, falls are not only serious from the standpoint of impacting people's lifestyle, impacting their independence, all those things, but adjusted for inflation, the direct medical cost for falls and the injuries related to falls is over $30 billion annually.
Wow.
That's $30 billion.
That's amazing.
And of course, hospital costs are a big part of that. But can you imagine the cost associated with nursing home care, surgical care, and the impact on lifestyle?
Sure.
When someone falls and breaks a hip, their life as they knew it oftentimes is never the same.
Right. And of course, there is the strong implication that if somebody falls and fractures a hip, that's usually a downward spiral in terms of longevity.
Yeah, you're exactly right. In fact, 95% of hip fractures, 95, are caused by falling. It's really, truly incredible. In fact, falls are the number one cause of injury-related deaths in people over 65, even more than car injuries, car accidents. And so the number one cause of injury-related death in people over 65 is falling. So it's a devastating. The statistics are just overwhelmingly devastating, and it points to the fact, especially when you look at the billions of dollars being spent, you have to ask. It begs the question: how much is being spent to prevent falls? And how aware and how active are physicians right now, whether they're internists or whether they're orthopedists or whether they're rheumatologists or podiatrists, how much effort is being done to help address and help reduce the incidence of falls? And it's a sad but true case that there's little being done. And I think that's one of the reasons why some of the efforts that we have started, as far as I do a lot of teaching on this, but some of the efforts that we've put together as far as protocols and devices and tools to help reduce falls is vitally important.
Well, that brings us to the next part of the topic, and that is that okay, a patient suffers from a fall. They're at risk for falling. It's very interesting. As I walk down the hallways of hospitals, I see stickers on doors saying fall risk, meaning if that patient is at risk for fall. Well, that's fine in a clinical setting. And it's great to know that our hospital personnel are taking the precautions that are necessary. What about when the patient goes home?
Yeah, so the first thing is that if a patient is at significant risk for falling, I mean, they're obviously in many cases the patients are, if they're not going home, they're going to go to a skilled facility, especially after a fall or something like that. So they may get some physical therapy and those types of things. But one of the best things to do when the patient's been in the hospital or for a fall, and if they're lucky enough, and keep in mind that when a patient goes into the hospital for a fall or for any type of thing related to a fall, most of them don't get to go home. Most of them go into a facility or something like that. But if they are fortunate enough to go home, there's a combination of things that I would recommend. I would recommend that a home health or home health agency, most of the time is going to be the one that does this, but specifically a home evaluation performed by a occupational therapist is vitally important. And there are home health agencies in Texas and around the nation that have fall prevention programs or policy or protocols. And so the first thing I would say, Ed, was that patient, someone needs to go through that house and identify, or at least train and educate the family about fall risks that are in the home.
Certainly. So, what would be your recommendation to the patient? Obviously, the patient is going home. I guess you probably would order home health care for that patient. If they qualify, of course. What else would you recommend or prescribe for them?
Yeah, I mean, home health is going to be vital, but I would want to see that patient. I would want to identify if that patient, most of these patients, most of them are going to have some biomechanical abnormality or weakness or instability in their gait. And someone has to tell this patient, again, unfortunately, someone in my position as a podiatric physician and surgeon, no one's telling the patients to come see me.
Right.
Unfortunately, when someone goes to their family doctor and reports falling, do you know the most common place they're referred to?
Where?
Is into an ENT. I mean, that's the most common place that balance patients are referred to. And, the first thing that's done when they're referred to an ENT.
Checked out for ear infection, yeah.
Well, they're given medication. I mean, they're given medication that oftentimes results in an increased risk of falling. So an ENT, of course, although I think that ENTs are extremely valuable, but I'm certainly not saying that ENTs aren't helpful. But oftentimes these patients do not get where they need to go. Their mechanical problems, their gait problems are not addressed by an ENT. That's not their area. A good ENT will oftentimes refer them to physical therapy, but even in physical therapy sometimes a thorough gait assessment is not performed there either. So I wish that I could see more of them, and there are, of course, there are good physical therapists who do fall risk assessments. There are good ones out there. Mm-hmm. Unfortunately, there's just too many places where there's no protocol. These patients don't know to send them to. But I say all that to say this, and that is that you asked me what else I would do. I would want to make sure that patient's in good footwear. And that may seem really just basic and simplistic, but you'd be amazed at how just adding good footwear can improve balance.
Certainly.
I'd also want to find out if they're a good candidate for the MBB, the more balanced brace. I'd want to make sure that they don't have deformities or weaknesses that can be addressed that are not being addressed. Keep in mind, Ed, that when these patients go home, unless they're told otherwise, what are they going to walk around their house in? They're going to walk around in slippers,
sure,
or flip-flops or something like that, which has been shown in published studies to actually increase the risk of falling.
As an orthotist, I often see a lot of patients who require some kind of an AFO or some kind of brace that would fit into their shoe. And just like you, you would be surprised at the kind of footwear elderly adults seem to wear. They get into a situation where they don't get dressed during the day. They quit doing that, and they start walking around in slippers.
Yes.
And that is, I would say, and I think you would probably agree with me, that probably is a huge risk for falling. But also being, you mentioned the fact of losing strength. What do you think about Tai Chi?
It's interesting you mention that. I don't. First of all, the first thing I'll say, just to back up for a second, if you don't mind.
Sure.
I work with the orthopedists. Our practice employs an orthotist, and I will tell you that I have the greatest respect for orthotists, and I have learned a tremendous amount from our orthotist, who is a veteran of 30 plus years. And so I can't overemphasize how important it is to have someone who is trained to understand the mechanics and how to stabilize mechanics are in the process. So that first, I wanted to say that first of all. The second thing is that when it comes to muscle weakness and when it comes to addressing these types of issues. Well, first of all, let me just repeat your question, Ed, real quick, just so I don't keep rambling. Repeat what you just said.
Oh no, that's you can continue. I was just asking you if you thought there was any benefit to
Tai Chi
something like Tai Chi in terms of strengthening.
Yeah. So my personal opinion is that Tai Chi is kind of a very vogue and very kind of. It's been popularized because there has been a study that actually was published that highlighted the fact that for those seniors who performed Tai Chi, that it maintained mobility and flexibility and reduced the incidence of falls. However, patients who are at really high risk of falling have no ability whatsoever, or very few of them that I see can do Tai Chi. Mm-hmm. And so, although it's kind of a flashy, new wave kind of vogue approach, here's where I think Tai Chi is the most beneficial. It's for seniors that have not reached that point where they're at risk.
So you would say it's prevention.
It's absolutely a great way to maintain flexibility and to improve proprioception. Tai Chi, entails going up on your toes. It entails going up on one foot and maintaining balance. So it's certainly an enhancement for those that may be beginning, into deficits and weakness and those types of things. But the patients that I'm seeing, Ed, are patients that are on walkers, that are humped over, patients that are dragging their feet, patients that oftentimes can't feel their feet. And although there are modifications of Tai Chi, like for instance, there are classes that we've put on in our physical therapy center that are very modified versions of Tai Chi, where they're not doing, extreme toe raises and doing those types of things. In fact, there's some good programs available in some physical therapy centers that do this. But I would venture to say, Ed, that in most cases for people that are at risk, people that would fail a fall risk assessment, that those people are probably past the point of being able to do Tai Chi, and those folks need to be in physical therapy and occupational therapy.
Having some technical difficulty. Okay, I want to ask you just a few things, whether you recommend them or not, so our audience can determine whether or not these are good recommendations.
Yeah.
Vitamin D supplements. What do you think about those?
They're well documented in the medical literature. They're well documented by the CDC. However, not everyone's deficient in vitamin D, so I would not do that without consulting with your physician.
True. Also, getting your eyesight checked might be a good idea too.
Yeah, absolutely. The vision problems are absolutely a vital. It's definitely a condition that's listed among the risk factors. There's no question. But what's higher on that list, Ed, are the use of medications like antidepressants or sedatives, or medications like gabapentin and meclizine and other medications that are known to cause imbalance and make you sedative.
Sure.
So anyway, that's an important risk factor as well.
And what about, obviously, you said you like occupational therapists going out, maybe a member of the home health team, doing an assessment in-home and recommending to you that the patient might need a prescription of various durable medical equipment, like grab bars and railings and things like that.
Yeah, a good OT. You're right on, Ed. I mean, a good OT. That's exactly what they do. They go in. They recommend. For instance, they'll go into the bathroom where a lot of falls happen, and they'll put bars around the toilet. They may oftentimes use an elevated toilet, and make those recommendations to the family to reduce the incidence of falls. Those are absolutely important things.
So tell us about, if you don't mind, tell us about the device that you have researched out and have been working with that helps with falls, preventing falls.
I appreciate you asking.
We're getting some feedback. I don't know if it's coming from your phone or not.
I'm sorry about that. I don't know what adjustments I can make. Is that any better? I've got to move my computer away a little bit.
You move your phone away from your computer. That's what's probably causing it.
Okay. Is that better?
Yeah.
Okay. Sorry about that, Ed.
That's okay.
So I would say probably close to 10 years ago, again, after working closely with my wife and actually really digging into the medical literature as to why people fell.
And back with us is Dr. Moore from Kentucky, and he is a podiatrist who has been talking to us about fall risk. And just as we were getting ready to go to break, I asked him a question and then stopped him from answering it. Sorry about that. Not good manners on my part. But anyhow, we had to pay some bills, so we went ahead and ran some commercials, and we're back. Dr. Moore, the question I asked was about the Moore Balance Brace. Tell us about that.
Well, so the brace, and again, we the term brace oftentimes has a different connotation, but that's not appealing to many people. But this we the medical term for these devices is called ankle foot orthosis. They're
correct. It is orthosis, but we have a little community out here in Texas called Paradise, and we like to keep things simple for them.
You're right. So these are devices that really came about as the result of just literally reviewing the causes of falls. So when you look at the top causes of falls, number one is muscle weakness. Number two, balance deficits. Number three, gait deficits. Those are lower extremity related problems. So when you look at the top 5 causes of falls, most of them are related to lower extremity or gait and balance that's related to the lower extremity. So utilizing AFOs like you do, Ed, and many people on your show know about AFOs. Are these the types of devices? Understand that these things are typically used for balance, but you have to ask yourself, well, how do you make a brace that can, number one, address muscle weakness and then can address balance deficits and all those types of things? Well, that's where that's where kind of the work went in, and the time and research went in to try to develop something for seniors that was easy to put on, that was lightweight, that would not be overly cumbersome. But the key thing is we wanted this thing to be flexible. We did not want to lock ankles. We did not want to reduce motion. We wanted to enhance motion. So there are 2 styles of the brace. There's one that is the standard type with the flexible posterior leaf type component. When you take the foot plate and it's very flexible. So we use that particular style for really probably the majority of our patients that are on walkers and canes that have a lot of instability. But when you watch those patients walk, it does not limit or does not prohibit sagittal plane motion. In other words, it doesn't lock the ankle up. The key thing in using a brace for balance is that it has to be something that, of course, is going to stabilize the ankle. And when you stabilize the ankle, you're going to improve postural stability, which is our ability to stand upright when, of course, we begin to lose our balance. So the brace does several things. It's designed to stabilize the ankle and stabilize the foot, but also improve proprioception, which is our ability to feel our feet in space, and thereby improve balance and reduce falls. So now, does the brace address all, every single cause of falls? Of course not. Is the brace for everyone? No, it's not. But I will tell you that I've been using the brace, and there are many other physicians across the country that use the brace, and for a large number of patients, it does extremely well. It helps improve their mobility, helps improve their stability. And we feel very confident that, and of course, I don't know if your audience may or may not know that there's been a couple of studies that have been done using the brace, one in 2014 in clinical biomechanics, and there are several others that are actually upcoming. So we're excited. I mean, it's just, it's not a silver bullet. It's not something that's going to solve everyone's problems, but it's something. And something is more than nothing, which is, for the most part, what's being done for these patients.
Well, what is since we're an internet-based show, where would someone take a look at this brace?
Well, so there's a couple of places. The first would be they can go into morebalancebrace.com. That's MOORE, balancebrace, all one word, .com. And they can get a quick overview of the brace. They can also go to ArizonaAFO.com as well. So that's Arizona AFO. So that's going to be 2 A's together. So ArizonaAFO.com. You can get more information there. The company that makes the AFO, it's made in the United States. It's Arizona AFO, and Ed, I'm sure you're probably familiar with Arizona AFO. A lot of orthotists utilize a lot of their bracing.
Certainly.
So they're a well-established and very reputable company that makes the brace. And Arizona AFO is owned by a parent company called OHI. And so you can go to one of those 2 places and get more information.
Well, Doctor, is there some daily exercise?
This is Mel speaking right now. Go ahead.
Is there some daily exercises a person can do to prevent falling?
Well, that's a good question. So when you keep in mind that there's a wide spectrum of patients at risk. So you have those that are on canes and walkers, who very likely could not do something on their own, and then there are those that are younger that still get out and walk. Those that are maybe in their late 50s or 60s that still are active yet have maybe a little bit of imbalance. I would be very cautious, and of course we have a sheet and information related to exercises they can do at home. But I would, as a whole, I would recommend that the patients do exercises under the guidance of a physical therapist or under guidance of some type of therapist. There have been many incidences of patients at really high risk of falling attempting to do, toe raises and other types of exercise, and they hurt themselves or they fall doing them. So the answer is yes, there are exercises for younger patients like Tai Chi, like we mentioned, patients that are able to have the flexibility and the wherewithal to do that. And then there are clearly patients who just do not have indication for doing exercises on their own. So I hope that answers your question. It's a good question.
Well, thank you. Yes, it does answer my question.
Well, there's so much more, Dr. Moore, that we could ask you about, and I'm sure we could glean a lot more information than we have so far. But time is time, and you do have patients waiting for you, and as we all do, or as we all have to get to our work days. So since we couldn't cover everything in very big-time detail, tell us, besides these websites, how someone can get in touch with you.
Yeah, thank you for asking. I would love for anyone who would like to email me and email me any questions, and I'll make sure that that I respond or forward you to the right location. But my email address is the letter J followed by Moore, so it's jmoore, JMOORE, at aappm.org, and that's Apple, Paul, Mary.org. That's jmoore at aappm.org.
And they can also go to www.moorebalance, BALANCE.com.
That's correct.
To glean some further information. So, Dr. Moore, we really appreciate the time that you've extended to us today and your knowledge.
Well, Ed, listen, it's been an honor and a privilege to speak to you and to all your listeners in Texas. I don't know if the majority root for the Dallas Cowboys or the Texans. Which one?
Well, we like to think the Cowboys, but just because we're here in Texas, since this is internet radio, we have an audience all over the world.
Oh, that's right. Okay, well, I tell you what, I hope that I'm a Cowboys fan myself, so let's hope that the Cowboys can
do it again.
Can have a good season, and always a pleasure to talk about balance. And so, thank you so much for the opportunity.
Thanks for being on. 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 Thanks for being on.